I really love orbital surgery, and well-circumscribed orbital tumors is an area that I'm very interested in. So I just want to give you a little overview of what an oculoplastic surgeon is probably thinking about when they see a patient with a well-circumscribed orbital tumor. I guess the first thing to do is to define what that really means, right? So there are a group of different types of tumors. Tumor can mean benign or malignant, but just that it's a mass that present in the orbit that are well circumscribed, meaning that they are well defined and delineated from the surrounding tissues. These generally fall into three categories, though of course, this is an oversimplification, but well circumscribed orbital tumors can include cavernous venous malformations. That's a benign, abnormal collection of blood vessels that has really very limited attachment to the systemic blood system. It can include schwannomas, which are a benign tumor of peripheral nerve sheath. So the cells, the Schwann cells that wrap those peripheral nerves, can proliferate and form this tumor or mass. And it includes solitary fibrous tumors. Now, solitary fibrous tumors have undergone many different name changes in the medical literature over the years, but they are generally felt to be a benign tumor with the potential for down the road or future malignant transformation. So in general, when we're talking about well-circumscribed orbital tumors, those are the three kind of diagnostic entities that we're referring to. Now, you might wonder what kinds of symptoms these patients often present with. Well, sometimes they present with slow, unilateral progression of a bulging eye, right? And they notice this, so they go to see their doctor, they get an imaging scan, and that's how this lesion is identified. In other instances, there can be some decreased vision, though that is generally less common with these types of entities. Sometimes there can be double vision depending on the location within the eye socket where this tumor is located and whether or not it impacts the ability of the eye muscles to move the eyeball. And sometimes they can just be picked up incidentally. For example, you go to the hospital for any other reason. You hit your head and you get a CT scan for this. Well, sometimes these well-circumscribed orbital tumors are picked up that way. Now, what do we do about them? Well, it really depends which of those entities we think the lesion is, based on imaging features on CT and on MRI, and what kind of symptoms it's causing. And then I guess the last thing to add on there is where it's located, because that helps dictate what the risk of surgery is. If it's located right at the very back of the eye socket, there's a much higher risk that it is associated with nerves and blood vessels that are really important. And so removing a lesion in that location carries a much higher risk of vision loss or double vision than removing something that's located in the front of the eye socket. So those are all of the different things that we're sort of taking into consideration. If it is a tumor that looks like a cavernous venous malformation, for example, it's not really causing any symptoms, then I think it's very reasonable to observe or watch those. Sometimes we'll get regular imaging just to keep an eye on it, see if it's growing in a way that would suggest A, a different diagnosis, or B, that it's going to become a problem within that patient's lifetime and would be better to remove now when it's a bit smaller. And sometimes, if we're either worried that perhaps this could be one of those conditions called the solitary fibrous tumor that has the potential to degenerate into something malignant down the line, or it's causing issues with double vision or unilateral bulging, the proptosis, then we'll decide to go ahead with surgery to remove these lesions. Surgery can be done in a number of different manners. It really depends on the features of the lesion, the size of it, and the location. Sometimes we'll go through an incision in the eyelid crease. We may or may not need to remove a section of the bone to access things during surgery, but I always put that section of bone back on. I think it leads to a better cosmetic outcome. Sometimes we'll go in through the corner of the eye here. The advantage of that for a lesion in the right spot is that you don't have to make an incision in the skin. And sometimes we'll do a combined approach where we go through the nose and through the eye socket at the same time so that we can approach the tumor from two different angles. So I really enjoy managing these. There's a lot of interesting things to take into consideration. In summary, we let the patient's symptoms and what we think is the most likely diagnosis based on the features on imaging guide our decision of whether to observe and monitor or to go ahead with surgery.